Good morning, Mr. Chairman, Senator Sanders, Ranking Member Burr, and Senator Enzi. My name is Tsung-Mei Cheng. I'm Health Policy Research Analyst at the Woodrow School of Public and International Affairs, Princeton University. Thank you for inviting me to testify. I have been asked to give an overview of single-payer systems, and I here distill my written testimony into a few salient points. An overarching point made in my testimony is that single-payer systems are not the same as socialized medicine or socialism, as is so often assumed in this country. In socialized medicine, government owns and operates the healthcare delivery system and finances it. The health system Americans reserve for their military veterans, for example, the VA system is purely socialized medicine. Single-payer systems typically are just social insurance, like the Social Security system. Under social health insurance, the government merely organizes the financing of health care, but the healthcare delivery system typically is private and can include for-profit entities. Medicare, for example, the social insurance, it is social insurance, but not socialized medicine. The main characteristics of single-payer systems are the following. They are ideal platform for equity in access to health care because everyone has the same insurance coverage and providers are paid the same fees regardless of the socioeconomic status of the patient. Single-payer systems typically are financed on the basis of ability to pay rather than on the basis of health status of the insured. Single-payer systems typically give patients free choice of doctors and hospitals. In single-payer systems, providers of care do not compete on price, but they must compete on quality of care, including patient satisfaction. In a single-payer health insurance system, health insurance is not tied to a job. Instead, it is fully portable from job to job when people lose their job and in a retirement, does not go away. Therefore, there's no job lock in these systems over health insurance. Because all funds to providers of health care in a single-payer system flow from one payer, it is relatively easy to control total health spending in such systems. The international data I cite in my written testimony make that clear. Now, some single-payer systems, like UK and Canada, may put constraints on the physical capacity of their health system, like number of hospitals and MRI scanners, as part of their effort to control total health spending, including waste created by excess capacity. This constraint may lead to rationing by the queue. The alternative to rationing by such administrative measures is rationing by price and ability to pay. Something that we see in the U.S. healthcare system. The argument that healthcare is not rationed in the U.S. is not supported by the data. A single-payer system is an ideal platform for modern IT. With common nomenclature, all billing can be done electronically, and it yields enormous savings in administrative costs. And because such an IT system conveniently captures data and information on all healthcare transactions, these systems provide a database that can know spending in real time and is, as in the case of Taiwan, and it is a base for use for quality measurement, monitoring, and improvement. And public satisfaction about single-payer systems is generally high. Denmark, for example, is ranked the number 2 highest in the European Union in consumer satisfaction. In Taiwan, public satisfaction is also very high, with a national health insurance program ranging in the 70s to 80%. In Canada, a 2013 international survey of 11 countries found that 42% of Canadians surveyed said that their healthcare system works well and need only minor changes, compared to just 25% of Americans who said that. 75% of Americans said American healthcare system needs fundamental changes or completely rebuilt. Lastly, survey research has shown that single-payer Medicare is very popular in the U.S. A final point is that every health system has its flaws, which can be highlighted with anecdotes. Therefore, there's now a brisk medical tourism worldwide. For example, Canadians come to the U.S. for health care, but it also is true that Americans go to Canada, Mexico, Thailand, and Taiwan for lower-cost health care. Thank you very much.